Vitality.
Vitality Unfiltered.
Unfiltered.
With David Bauder.
And we are back for another episode of Vitality Unfiltered. I'm David Bauder, your host. With me today from Weight Loss and Vitality is Dr. Christopher Reeves, medical director, and nurse practitioner Stephanie Lattimore from the Washington, D.C. clinic. Today's conversation will be centered around why lab test or blood work matters after the age of 35. Most people don't get labs until something is literally wrong. Or they go in presenting of a symptom or a condition, and blood work is done. Our healthcare system currently is completely reactionary, not completely, all right, but it's largely reactionary or reactive to complaints of symptoms rather than more of a proactive or preventive strategy. Patients really need to think about labs as data. Data is power, and the more data you have, the more value it has over years of looking at it. And that's really what we want to get into, is to explain this concept and make sure people feel comfortable in searching out, seeking labs, and getting blood work that they can use and leverage later on in life. Ms. Stephanie, how do you use labs or what do you use or establish labs as kind of a foundational tool?
So as you mentioned, labs serve as a huge piece of preventative medicine. Establishing this baseline for patients can be very beneficial, not only to look at their health now, but to serve as a baseline for future and to trend this data to tell us a lot about a patient's individual health. When I have a patient come in, I will draw their labs and it will serve as a great data point, but it doesn't really tell the whole picture if I don't know their labs, what they were before. So it's really good to trend this data and to track this over the course of a patient's life.
I couldn't agree more. I mean, like all of the patients we see at the clinic, I mean, you just nailed it. It's like all of the patients we see, wouldn't it be nice if we could have seen what their normal blood test looked like 15, 20 years ago? And it's just a snapshot in time that we get those blood work. And when we think about modern medicine is set up on reference ranges. It's all about reference ranges. Again, we're going to be talking a lot about modern medicine here or our current healthcare model. Reference ranges, Dr. Reeves, why don't you go ahead and kind of like talk through that whole concept of what reference ranges are and how they're interpreted in the use of labs?
So a reference range, oftentimes people can look at them as the normal, quote unquote, normal range. I'm using air quotes, normal range for labs. So what that means basically is it does not necessarily mean normal. It basically is a statistical measure of where your lab result value falls within that population from which that lab is drawn. So if you have a population of people who are getting sicker and sicker, more and more unhealthy, and there's a shifting of those labs, but as a population gets sicker, that quote unquote normal range shifts along with that population. So it's not a true measure of wellness if you get a normal result. A normal result, you need to do a little bit deeper digging and more precision testing to find out what is normal for that individual as compared to the standard LabCorp Quest normal reference range.
How would we ever come up with, so we got the reference range, but how could we ever come up with the optimal range? You know, like years ago, I went to the A4M conference a while back, and there was one lecture, it just strikes me, in one of the lectures that was being presented, an individual got up there and did a whole presentation on optimal hormone levels for women. And they went through, by the numbers, sex hormone, binding globulin, progesterone. But these were, somewhere along the line, these numbers, these optimal levels or these optimal blood test levels, they were established. But nobody really uses them other than integrative functional medicine. In Western medicine, it's really all about the reference range. You fall in the reference range, you're good. I mean, what kind of effort would have to happen to get Western medicine to say, okay, yeah, that's the reference range, but what's the optimal range?
Well, I mean, I think a problem with that would be is if you start testing people for optimal ranges and getting what is actually disease state versus healthy state would require more intervention. One of the biggest things I see since 2010 is like this term pre-diabetes. It's becoming more and more popularized now. Every patient I see in the morning, I'm an anesthesiologist, I see them, do you have diabetes? Well, I'm pre-diabetic. Well, what does that mean? That means that your labs are on a continuum towards diabetes, but the switch for diabetes didn't turn on until you hit that one number. And once you hit that number, then you're now diabetic, and now you can get reimbursement for your medications. You can get treatment for this. You can get treatment for that. But it's not like diabetes is something that is a on and off switch. Like it's not like a point in time where that disease process causes problems or it doesn't. It's a continuum. And so giving optimal ranges, you may have an optimal hemoglobin A1C or a fasting glucose level that may fall in the quote unquote normal range, or this pre-diabetic range, or pre-insurance will pay for it range. And you have significant disease going on that should be treated at that point, but it's not going to get reimbursed. It's not going to get looked at. It's not going to be flagged as being abnormal until it crosses that threshold.
And the incentive to ever get that blood test to be the correct blood test is like, that's all. It's like practically the incentive is zero, because if they were to open up the door for treatment for prediabetes per se, insurance reimbursed medications
would go way through the roof.
Instead, they're just.
Telling you, like I'd say at least a good 50 to 70% of the patients that I see that to the diabetes questions, they say pre-diabetic to it.
Do you know that I had a young patient, late 20s, who had a A1C of 6.4, and her insurance denied brand name
6.5.
because it has, because the data, the reference range says it has to be greater than 6.4, and they denied her. Yeah. How close do you want us to get?
And then this is exactly right. So I don't know. I think Dr. Reeves was telling you about recently he was working and I got him on the phone.
Oh, yes. Yeah.
I got him on the phone and he's talking. They're admitting a patient. They're going to do surgery, right? And then in the background I hear is like, okay, this patient's got pressure ulcers, bed sores, right? And I mean, it's just going down the checklist, right? And I'm just like, oh my God, right? And this is exactly what we're talking about here. Prevention, right?
Not reactive.
Like, that patient at one point in time had a hemoglobin A1C of 6 or 5.9 or 5.8 or 6.1. And that patient wasn't treated.
Was denied treatment because it did not reach that point.
So now look at now
we're dealing with things at a much later stage. With where the insulin resistance is through the roof, to the point to where she's not healing. She has wound healing. She had this dislocated hip. Pressure sores because she can't move. All of this is a metabolic syndrome.
Nightmare.
Absolute nightmare. But this is what we see every single day, is the end result of all these things, and not, something that has been dealt with and prevented. So optimal labs, if that was the norm, that lady maybe would still be in the hospital from a dislocated hip, but maybe she wouldn't have the diabetic metabolic syndrome, and she maybe would heal faster and get out of the hospital faster and lower the total cost of care. But that's something that I think is we have a little bit more work to do to get to that point.
Right. Wow. It's a lot to think about. Steph, when we think about working up patients, what kind of labs are we talking about when we think about that 35 plus patient? What labs are we going after?
So in addition to the baseline CBC, the blood count, the metabolic panel, the A1C, when I think about more metabolic picture, big picture, absolutely a thyroid panel for those patients, and the sex hormones. I love to establish a baseline kind of sex hormone panel on a patient 35 or older. We don't know when men are going to enter andropause. We don't know when women are going to enter perimenopause into menopause. If we had their baseline levels where they were feeling good and asymptomatic, what a great tool that would be to target those numbers when they do go into natural menopause and andropause. Other labs that I would recommend anyone over 35 to establish more of an adrenal picture, you could draw a DHEA, pregnenolone level. Those would be kind of telling. We talked about cortisol a little bit, but it's not on the top of my list, but it is definitely worth the conversation with the patient. And some baseline inflammatory markers like high sensitivity CRP, C-reactive protein. That'd be great to just establish a baseline.
Even the regular CRP, I love to use that as a tool just to see what kind of inflammation is in general body. Again, the reference range on a C-reactive protein, which is an inflammatory blood test. The ESR and the CRP are standard inflammatory blood tests. And, I think the range on a CRP is like 1, the reference range is like 1 to 4 or 1 to 5. it should be 0.5. You know what I'm saying? It's like if you're doing things right, it should be 0.5 or 1 or below. I mean, it's just how it should be. And if it's a 3 or if it's a 4,
that's normal.
Something's going on.
that's normal, but something's going on.
Something's going on.
And likewise with the sex hormone binding globulin that you talked about, if a person's doing pretty well and their hormones are balanced, they're going to have a low sex hormone binding globulin. But if you've got a really high sex hormone binding globulin, I don't look at it as the lab. I look at it more as that's a symptom of something else is going on. You know, it's almost like a telltale sign that there's something else. Either you're not eating right, there's some type of metabolic disturbance, you're on some type of medication, something like that. I mean, how do you see labs like trending over time? Like,
yeah. So actually, there's studies that show that the typical model of snapshot in time doesn't really give you much. It tells you where the patient is at this particular day, this particular time, but it does not give you the full picture of what is going on with this patient, whether or not they're moving up the healthy curve or down the healthy curve. There's studies that show that doing longitudinal labs and studies to see exactly where the patient is over time can increase predictability for conditions and diseases up to 50% better than a snapshot. So there's evidence there that shows that getting trend data is much more superior to just a snapshot or single shot. And then when you combine that, as I think we're going to get into with genetic screening and testing, you have a powerful combination there of sequential longitudinal trend lab data associated with predictability of potential future metabolic or medical problems from the genetic screening.
And then it comes into the oversight of the labs too. Your data, marching it out, looking at the whole thing, but a lot of this is looped into the patient's symptom. What are they originally coming in for? What is their original complaint or the symptom? Like two people can have the exact same lab value, but a different symptom, and that triggers like, okay, that lab is associated with that. It's like labs by themselves can't be in a silo either.
Right.
It's another piece of the data that matches up overall with what you're about. What's the intake? What's the past medical history? What are the patient's symptoms? What are the other lab presentations show? It's all of these things collectively that matters. When you have patients that come in, I don't really have patients that are avoiding labs, but I think that, we would, if patients are avoiding labs, we would never see the patients. So why do you think patients out there that don't get labs, what do you think causes it?
There's a lot of reasons a patient would defer labs and avoid labs. There's a fear. Some people have a fear of needles. It's valid. A fear of what they don't know. They don't want to know what they don't know. But data is power. Knowledge is power. I think there's a fear of being overwhelmed by the data. Primary care will draw your labs and then they'll never explain them to the patient. They'll say you look good, see you next year, and things are just minutely off by 0.1 or 0.2. And I've seen patients go down a Google MD search of why is my Nutrafol 1 point off, and then it says something crazy like you have cancer. So I think they don't know. They're afraid of what they don't know. They don't know what they don't know, and no one's there to explain to them what the labs mean. I have another group of patients who don't know how important labs are. This is a minimally invasive, phlebotomy is pretty easy, pretty quick, safe, and it can tell us so much about a patient's underlying and overall health. So I think they don't realize the importance of labs and how crucial they are and how much information they can tell us.
There's some studies out there that show that like patients who are informed about their labs and have this longitudinal kind of follow-up, they have better compliance and better adherence and better outcomes. Because they kind of, especially if you, like you said, traditional primary care doesn't explain what these labs mean. But sitting down with a patient, taking, when you have the time to be able to explain why this CRP level is this and what it should be. And, they understand a little bit. They don't have to understand it at the clinical level, but they understand it in kind of a broader layman's terms. They understand why going to the gym 3 instead of 2 days a week is going to be better because I'm looking for these numbers to come down or these numbers to come up. It helps to increase the compliance.
I can totally see that.
Yeah.
Like even with patients with elevated hemoglobin A1C and marginally elevated, even if it's like a 6, and you really spend the time and you explain to them what that hemoglobin A1C blood test is and how it's associated with your red blood cells and what it's linked to and the risk of diabetes. And you stress the importance to the patient as far as what exercise will do to lower that, eating less carbs and sugars will do. And if you don't embrace this will happen. A lot of patients, they'll use that as a tool and they'll be like, and they want to know every 90 days, they want to know what their A1C is. And
you can tell those patients that follow it and know. I see it on the other end where they say, oh, my A1C was 8, but it's down to 6.2 now, or it's down to 5.8, they know their numbers. And it's because it's almost like a Hawthorne effect. Like, they know that they're going to come see you in 3 months and they know that you're going to be looking at your A1C and they know that these are the things that Stephanie explained to me that are going to raise my A1C. I better not. I don't want to have to face Stephanie with my number. Yeah. So there's a little bit of that game theory, competitive stuff in there as well that can assist.
I definitely use that as the education tool, to show them this is this is full-blown diabetes. This is where you could be if you continue your lifestyle. And this is where we want to get you with lifestyle changes. It's very easy for a patient to kind of say, okay, these are the changes this is what I'm doing and this is what I need to change. Cholesterol too, I have that conversation. This is your cholesterol, good versus bad. And then I'll get down to the LDL and I'll say, so how's your diet? I don't want to speculate, but they'll say, well, I do enjoy my ice cream or my cheese. And I'll say, those are some, lifestyle modification changes that we can make.
I'll on the cholesterol piece, I'll actually throw on the other side is like, sometimes patients are too concerned about the cholesterol.
That's correct. Yeah.
And the
lipitor stuff.
That's right. And they're not informed about the, cholesterol is needed in the body.
Cholesterol is a precursor for all these hormones we're talking about.
That's right. Right.
Cholesterol comes in, it becomes cortisol, testosterone, estrogen. It's not all bad.
It isn't.
Yeah.
And they're sometimes just so concerned about that total number. Oh, it's above 200. I'm like, no, it's okay.
But the HDL is the high density lipoprotein is high. It's good. Your healthy fat is high. That's a good thing.
You know where that came from was that study that they did that started the whole market for the war on cholesterol. And I mean, at that time they were, because of that study that was done, I think it was done in the UK. I think it was a study out of the UK, and they again put everybody in the study, smokers and everything, all age groups, everything, botched study, and anything over 200 is bad. If you have a high cholesterol over 200, put on Lipitor.
And I can't tell you, every patient I see is on Lipitor.
Yeah.
And they don't need it.
Yeah, but how's their blood pressure? Because if it's pretty good, I'm not as concerned about bad cholesterol, to be honest.
Yeah. So when you work a patient up, like what, like if you ran through the labs and you're working a patient up, what are overall the preventive lab tests that you are ordering them?
Okay, so preventative CBC complete blood count is going to look at your white blood cells, your red blood cells, and your platelets, and a breakdown of all the different types of white blood cells in the body. Very helpful for underlying inflammation and infections, if there are any, if a patient was just getting over something. So that's very valuable insight. Sometimes I can even suspect an underlying anemia or like deficiency if some of the blood counts are off, the size, shape, and color of the red blood cells are indicated or in the CBC. Comprehensive metabolic panel, liver function, kidney function, and the electrolytes. So that's a big one too. That's very good to know. And there is a correlation between the liver enzymes and the cholesterol and that diet and nutrition piece too. So that absolutely ties into lifestyle changes and modification. TSH, thyroid stimulating hormone, thyroid panel, huge. Everyone should get that drawn. Absolutely. The A1C. And I'll have a lot of patients come in, younger clients, and I'll be the first provider to ever discuss and draw their hemoglobin A1C. So it's unfortunate when I have to tell a young client they have prediabetes or diabetes.
Yeah. That's a lot. It's real.
It's real. It happens.
Absolutely.
And like the client I mentioned earlier was in her late 20s, so it's not unheard of. I think those are pretty much the big ones.
And probably drop the hormones and then add some hormone. If I think it's just always a good idea to add the hormone panels in there, so they have a hormone test when they're younger, so you can always go back and reference it. And even with the estrogen and progesterone, I love to tell the patients to draw it on day 21 of the menstrual cycle. It's just a really nice set point that you can kind of like validate that.
And you mentioned context is everything. So not every patient needs every lab drawn. We're really looking at the context of concerns, symptoms. Establishing a baseline is huge, but I'm not going to draw an anemia panel on everybody if they don't have concerns, and especially if their CBC is normal.
That's right.
So I'm really paying attention to how they present. I thought of another reason why sometimes patients are kind of deterred from lab draws. Our culture and our society puts a lot of pressure on patients to advocate for themselves. And it's hard if you're not medical. It's hard to say, I want you to check my vitamin D level. I want you to check this. So for example, my husband has been going to our GP every year, and I say, you got to get your thyroid checked. He has a family history of Hashimoto's, hypothyroidism. And every year they check his TSH and it's normal. He didn't know he had to state that his mother had Hashimoto's, and they have to actually check that thyroid peroxidase antibody. It's very nuanced. So to walk out of there and say, yep, my thyroid's good, it's really not. They didn't really check what we were kind of targeting. So puts a lot of pressure on the patient to advocate for themselves. And it's a lot more nuanced than that.
And nowadays, we have obviously the traditional lab testing that we're talking about, but the next step, what we're going to see in the future, and we do some of this at our clinic, is the genetic aspect of testing. And I think that's we alluded to this a little bit in some other episodes, but that's going to be the game changer in long-term medicine. Nowadays we use an organization to test genetic testing through an organization called Extending Me. And quite honestly, for the listeners out there, extendingme.com, any of you could go on there and order your own genetic testing if you wanted any type of specific blueprint of the future. And they do everything from brain health, looking at the potential and risk factors for Alzheimer's. They have 2 different ones for that. So looking at dementia, longevity aspects, a psychological panel that can look if you're taking certain medications, with medications would work best for your certain psychological diagnosis, perhaps depression or anxiety. They also have a lot of food intolerance ones, would look at how you digest macronutrients, whether you can handle. I learned when I did my food tolerance test, I learned that I don't process multigrain carbohydrates very well. I had no idea. I mean, I would have never, you walk around and think multigrains are healthy, but my genome type just doesn't do very well on multigrain products. So there's a lot of value in that. Thinking like long term, I love the. They also have the really great genetic testing now that does the biological aging aspect, chronological versus biological aging, the epigenetic test. It's kind of interesting because if you have this done, you can kind of see the rate at which your genome type. I hope I'm saying this correct. This is, but it's kind of what it does is it looks at the methylation of your genome type at the rate of which you're methylating your genomes. And by doing that, you can kind of measure, like, are you aging faster than your genetic says you should be aging? It's kind of useful. I mean, you have anything to add on that?
But I think that's it's a new insight in terms of what we're able to see in terms of very nuanced things. So for example, like we talked about, like the hormone replacement, categories. There's some genetic variants that certain types of medications will work better than others. Like you said about the food intolerance things. So a lot of things that we can get insight that we can get from these genetic tests that can allow us to make these more precise changes in terms of treatment or lifestyle changes that can dramatically improve the longevity of our life. And it's relatively new now. It's kind of getting more popularized, and the more popularized it gets, the costs for doing these tests are coming down. Just a year ago, the costs were probably about 50-60% higher than they are now. So it's gradually coming down more and more and making it more affordable. And, like I said, we're doing it here to be able to be more proactive with patients. But I think this is a good opportunity in the future to where we can actually do even better than what we're doing. And I think that the functional and precision medicine clinics will be the ones at the forefront of this. And it's going to create that gap between traditional medicine and clinics like this, even wider in the coming years.
Yeah, I like to say regular biomarker lab tests like hormones, CBC, A1C, that's here and now current. with trending potential. So you can see where you're going. But then the genetic piece is the blueprint for the future. So you can, if you put those two things together, you piece current labs with trending and the genetic component, that is precision medicine. That is when you're bringing everything to the front. And that when you think about the genetic aspect of this, you want to do it as young as you can. You want to do the genetic testing early on in life that you can turn the ship. So if there's some things you can do at an early age, you should get the genetic testing done soon, because if you wait till you're 70 years old to do genetic testing, you have a limited shot group here to try to turn the ship and influence where you're headed anyway. So do you guys have anything else?
No, I completely agree that data is knowledge and knowledge is power.
That's right. Yeah, so I just would like to encourage everyone out there, don't wait till you're sick to get labs, okay? Don't be intimidated by them. It's not that big a deal. Be an advocate for blood testing, request labs. Keep in mind, a lot of times your insurance carriers will not pay for the blood work that you actually want to get. But if you're informed and educated, there are a lot of clinics out there that will get you the blood test that you want to, and it's not an affordability problem. A lot of these lab tests can be done at a very, very reasonable level. And I want to thank each and every one of you for attending and listening to our show today. And if you enjoyed the show, make sure you click the subscribe button below, and we'll see you on the next episode.
Thanks for joining us on Vitality Unfiltered with David Bauder. Addressing norms, busting myths, and uncovering health realities for a more vibrant life today. For more expert insights and real talk, make sure to subscribe and join us next time.